So hey, thank you very much for taking care of my patient today. I really appreciate it.
Oh, you're welcome.
So a couple things I just wanted to go over with you about him. We did a lumbar fusion surgery for him today, and everything went very well, but there are a couple things that I want to make sure we're checking in the post-operative period. Obviously, most important thing after a spine surgery is doing a neurologic exam. And so we'd like you to be checking that routinely at the beginning. Usually we've done on an hourly basis and then a Q2-hour basis. And if there's any change from what their baseline exam is, we'd want you to let us know right away. And just simple things. If you noticed a patient had new weakness or new loss of sensation, that would be concerning enough for you to go ahead and give us a call so that we could try to find out if it was expected or something that we had to be more concerned about. That's the most important thing right off the bat. We also really care about their pain control, and so most of the patients after fusion are going to come up with a PCA, and so we'll want to make sure that their pain is adequately controlled. And there's two real benefits to having the pain control. One is so that they feel better, but the real goal of pain control for us is to get the patients up and mobilized as quickly as possible. So unless there's a reason, like if there was a complication in the surgery or there was something unexpected, we want all of our patients up the day of surgery. And just like we talked to them about the risks of potential surgical complications, all post-operative complications are directly related to immobility. So the sooner we get our patients up walking, the less I have to worry about things like blood clots, pneumonias, ileuses, or things like that. So we know that even if we just get them up that night for a couple steps or even just to stand by the edge of the bed, that gets their body processes working a little bit more specifically.
Okay.
And those are really my main, the most important things that I think about after surgery. Obviously, it's usually concerning enough or significant enough if there was ever any change in the neurologic exam, we'd all want to be told right away.
Okay.
Are there any particular questions or practical questions I could go over with you?
Yeah, I do have a couple.
Sure.
Is an anticoagulant indicated?
So with spine surgery, it's a little bit different than other surgeries and total joint surgeries. We're actually more worried about an epidural hematoma than we are about a blood clot. So unless their patient has high risk factors and morbid obesity and we're not expecting any movement or we're not expecting them to be mobilized and up and out of bed, the majority of us do not want to do any pharmacological anticoagulants, but instead we'll use the mechanical ones like the SCDs and the TEDHOs and things like that. We're all pretty religious about that. There might be some variation based on the patient's history, whether or not we let them start an aspirin early, and if they develop a new cardiac event post-operatively, obviously we have to factor that in. But in the initial setting, we usually use the mechanicals as our primary anticoagulant device, and also mobilize it, getting them up as quick as we can.
Okay.
And that actually reminds me of one other thing, is that a lot of our patients you're going to find come up with a brace, and you will see some variability in the way that different physicians utilize those. What most of us use the braces for is to help with that immediate mobilization, especially for the open cases instead of the minimally invasive cases that can be a little bit more localized back pain. And so what we use the brace for is to give them that mechanical support, give them that psychological support so that they're feeling better, so that we can get them up moving, again, to help decrease all of those potential complications that we're worried about.
Okay. All right, thank you. All right, and then what is the purpose of the drain? Is it typically to gravity or suction? And what to do if it becomes disconnected?
Great question. So the idea about a drain is you want to create a path of least resistance so that you can get the fluid out so it's not putting stress on the wound. That'll allow the wound to heal. Also can help potentially decrease the potential for epidural hematoma or things like that. The times that we would put one on gravity, number one, if there's excessive drainage, some of us might say, okay, hey, let's switch that to gravity so that we're not actively sucking all of that out, so we're letting the body have a better chance to coagulate on its own. But the most common reason would be if there was a dural tear. And so when there's a dural tear, when there's an injury to the lining around the nerves, typically we'll either repair that ourselves or we'll put a patch, but we use the drain to gravity because we don't want to create a negative pressure area. We want to allow the body to heal that as quickly as possible.
Okay.
Do you know what a dural tear is?
I've seen a couple patients with a dural tear.
But do you understand what the idea is?
Yeah, I just know that they have to lay flat when they first come up for 24 hours.
And so, again, we all have our own different protocols, and the way I explain this to patients is basically imagine a water balloon with spaghetti on the inside. the spaghetti's what matters. That's the nerves. The water balloon just helps hold all the nutrients for that nerve around it, and that's the dura. And the reason that we keep you flat is because if you sit upright, it's like a water column. It puts more pressure on the repair, and we know that that first repair is the best repair. So a lot of us will keep you flat, some for 24 hours, some until the next morning. Some are more comfortable getting them up based on the quality of the repair you had, if it's an open case for a minimally invasive case. But the idea is that you're keeping them flat to decrease the pressure so that your body has the best chance to clot that and heal on its own. Now, me personally, I allow patients to go side to side because it's not causing increased pressure. There's a couple surgeons I know that actually even put the patient down with their head down to take even more pressure off, which is not the nicest thing in the world. But I do think side to side allows patients a little bit more comfort with eating, changing positions, especially like that.
Okay.
And your last question about if the drain came out, I certainly don't want anybody trying to put a drain back in.
Yeah.
So if a drain comes out, we want to reinforce the dressing and notify us as quickly as possible. If it's one of those connections and it's safe, then that's reasonable, but you don't want to introduce anything.
Okay.
And most of us are trying to get the drain out as quickly as possible, so sometimes if that happens earlier than we had planned accidentally, that's not always a bad thing.
Okay. And then what about the Foley? If it has patient has a Foley, when's it appropriate to remove it?
It's great. So I think about Foleys in a similar way to the drains and a similar way to mobilizing them. We want to get them out as quickly as we can, but if the patient is not able to ambulate independently, we don't want to create a non-hygienic environment for them. So my personal protocol, and people do have a lot of variations in it, is I'm okay with the Foley being removed as soon as the patient is up and ambulating. My hope is that happens the night of surgery. If they can only get up and take a couple steps, and we're worried about, if it's a female, if we're going to be using, a pan, and that might have some potential contamination to the incision, or if a male might not be as compliant or capable of using one of those bedside devices, then it'd be reasonable to do that the next morning. But in my mind, once a patient is safe to be up and walking, we'd like to get that out of them. Number one, you just decrease the infection risk. But number two, getting up and moving and getting from the bed and going to the bathroom is their physical therapy. And so that's what we want them doing at the beginning.
Okay. All right. And then would you like your patients using the spirometer, the incentive spirometer?
Yeah, so incentive spirometers are all of our best friends so that we don't have to worry about fevers and things like that in the immediate post-operative period. So I'm a big fan of that. My order set says use 10 times every hour. I want what I tell the patients when I'm talking to them, if you're watching TV, every time a commercial's on, just get to doing it. And because we know, again, that that'll decrease the chance of atelectasis, decrease the chance of a fever that may need to be worked up, decrease the chance of pneumonia and things like that. Okay. So once they're up and walking independently and ambulating on their own and back to normal, it's not as integral, but until we get them to that point, I think it's a very key ingredient to the nursing.
Okay. And then one more question. So what are some precautions that you need to know to take care of and teach the spine patient, and for how long do they use the precautions?
So that is a huge question, and I think it really matters whether we're talking fusion, non-fusion, cervical, and lumbar. But when a patient has a lumbar fusion, the number one thing that we're worried about is really we're not worried about them moving in such a way that the hardware falls apart. What we're really worried about is moving in such a way that they're going to harm themselves, so that causes pain, and that sets back all of our advancements that we're trying to do in the post-operative protocol. So the physical therapists are very good at explaining all the different particular BLTs, and what I tell patients to do is you want to avoid any unnecessary bending or twisting. I operated last month on a single mother of an 8-month-old. Well, she's going to have to bend over to pick up her kid, but you want to do that in the right way. You want to make sure you're doing good body mechanics, that you're appropriate, that you're moving appropriately, and that's really what the therapists are so good at helping them with. In the immediate setting, I like my patients to have their brace on when they get up and out of bed. Okay. I think that is a mental reminder and a physical reminder. But a lot of, some of my friends don't really aren't as adherent about a brace, so I think that's something that would be more on a per physician basis.
Okay.
As to those precautions.
Okay. All right.
Sound good?
Yes.
Well, thank you very much. Thank you for taking such good care of my patient.
Oh, thank you very much for all the information.